over the last 2 decades, I have tried to avoid excision of the infected aorta because I don't think these patients tolerate this type of surgery well. I will follow my usual habit and bring a very recent case. This is from a few weeks ago in Copenhagen. Actually, you see a lot of these patients if you start looking. This was a male 75-year-old who had open repair of a ruptured aortic aneurysm in 2006 with a tube graft. In 2013, the aorta looked fine. This is at the level of the infrarenal anastomosis. There was a bit of intestine right next to the right next to the aorta, but no signs of any infection. In August, he started to have repeat GI bleeds, and he was several times in shock. Another CT was then done, and you can now see that that piece of bowel is in closer contact with the aorta. There are inflammatory reactions and a tendency to form a pseudoaneurysm. What I do typically to confirm if there is a fistula or not, I do an endoscopy, and I ask the endoscopist to place a clip if they see a source of bleed. That was done here. You can see the metallic clip, and it was right next to the aorta, so we were pretty convinced that it was an aortoduodenal fistula. The question is, what do you do now? If you go to the textbooks, everybody will tell you that you have to do radical surgery. In real life, I find that difficult and dangerous on most occasions, and this particular patient had this beautiful remnant of his previous open surgery. I don't think he was a candidate for open repair, having this huge hernia, and his whole condition didn't allow that type of surgery.